like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series, and I'm also a patient living with MPA vasculitis. And today's webinar is questions and answers on medical access. And we're grateful to have with us Dr. Rachael Parrott, who is going to educate us and answer some questions. But before we get started, let me introduce Dr. Parrott. As she likes to go by Rachael, that's what I'm going to say going forward. Rachael Parrott is the clinical pharmacy specialist in rheumatology at the Hospital of the University of Pennsylvania, and she's been a practicing pharmacist since 2006. And Rachael, well, first of all, welcome today. How are you doing?
I'm doing well, thank you. How are you?
I'm good. And before we get started, I'm supposed to ask if you have any disclosures.
So I am I've been on advisory boards with Janssen Pharmaceuticals, and I am currently on the Speakers Bureau for Janssen Pharmaceuticals as well.
Okay, well, thank you so much. And I think today we're going to start with something special. We have a quiz, so to speak, for all of our viewers to watch, and I am going to attempt to share my screen and see if we can get the quiz going here. Let's see. All right, you should be able to see our first question, which is, how old do you have to be to begin receiving Medicare? The choices are 55, 60, 65, or 70. And the answer is 65. Rachael, do you have any thoughts about that?
So I think some people might have some questions about that question, and actually our next question kind of goes into situations where you might not have to be 65, but 65 is currently the cutoff for most people who would start receiving Medicare.
Okay, and speaking of the next question, which has to do with that, true or false, people under the age of 65 living with certain disabilities may also be eligible for Medicare benefits? And the answer is true. So that's what you were just getting to, I believe.
Yes, so people with certain chronic conditions under the age of 65 will be maybe eligible for Medicare benefits.
Sorry, my thing keeps advancing before I'm quite ready. So the next question is, Medicaid is A, federal program, or B, a state program operated through federal guidelines? And I have to admit, I did not know this answer. So the answer is, it's a state program operated through federal guidelines.
Yeah, I think that that is one of the misconceptions about Medicaid. Medicare is a federal program. It is provided by the federal government. Medicaid is actually operated on a state-by-state basis. So you might find that the rules with Medicaid are a bit different state to state. It is operated through federal guidelines, meaning there's a minimum standard that each state has to have, but each state has a bit of a different program with their Medicaid programs.
So as you said, Medicaid can vary from state to state, but Medicare is the same no matter what because it's a federal program?
So for Medicare A and B, yes, Medicare is the same across the board. Medicare Part D, there are federal guidelines that say this is the minimum that is required through a Medicare Part D plan. But Medicare Part D actually is kind of a special case. Even though it is a federal program, it is actually administered by multiple different companies throughout the United States. And that's why I think we do have a question about enrollment for Medicare Part D in here. So each Medicare Part D plan has its own benefits that are at least the federal minimum, but it is different from program to program on what they actually offer.
That is interesting. Okay, moving to our next one about Medicare Part D. That refers to which benefit? Hospital insurance, medical insurance, Medicare Advantage, or prescription drug benefit? And the answer is D, prescription drug benefits.
Yeah, so the Medicare Part D is something that people can opt into. So even though people are eligible for Medicare at age 65, the prescription drug benefit, the Medicare Part D program, is actually it is not required to be enrolled in Medicare Part D if you're a Medicare enrollee. So it is a prescription drug benefit. And like I said before, there are minimum federal requirements for Medicare Part D, but it may vary on what is covered between program to program.
It's interesting because when I was starting to learn about Medicare, there were so many components of it for somebody who had been on, like an employee's health program in the past. And one of my friends said, just remember when you get to Medicare Part D, D stands for drug, and it refers to your prescription drugs. I said, oh, I can remember that one. Good
Yeah,
little.
and I always recommend, when people are getting ready to enroll in Medicare, to actually work with a Medicare broker. So Medicare brokers, actually, it's not something that you have to pay for. It's kind of built into the cost of Medicare. So if you are a Medicare enrollee, looking to become a Medicare enrollee, or even if you're looking to change your plan, definitely recommend working with a broker. These are people who are very familiar with the Medicare Part D plans, and they can help pick out the best program for you, so that you can get basically the most bang for your buck, so that you are, actually getting the most benefit out of your prescription drug plan.
That's really great advice. Not something that the average person may know, since I'm average and I didn't know that. Okay, the next one is Medicare's open enrollment period occurs annually from A, October 15th through December 7th, B, September 15th through October 31st, and C, October 1st through November 30th. Wow, I thought I knew this, but this is maybe not. And the answer is October 15th through December 7th. Yeah, I would have gotten that wrong.
Yeah, so it's nice that there is open enrollment once a year, because if you happen to have a plan, or if your health needs change from year to year, it's important to know that there is that option to look into additional or different plans moving forward, so that you can get the right plan for you.
And so that's the time period where we make all those decisions and make any changes, but those changes take effect in January of the following year, right?
Correct.
Okay,
Yes.
that makes sense. And the next one is, according to federal guidelines, Medicaid must cover which of the following benefits? Coverage for hospital stays, that's A. B is home health services. C is transportation to medical care. D is family planning services. And the answer is all of them. Oh, I'm glad to hear that.
Yeah, because Medicaid is a program for those people with lower income, they require often assistance with most things associated with any sort of medical hospital stay, procedure, transportation, and medical care. So this is for people who may not have access to a vehicle, but also may have health problems that prevent them from taking public transportation. So it's really important that all of these things are covered for Medicare, for people who are on Medicaid.
Interesting. Okay. And that concludes our question and answer slideshow today. But we do have some questions that have been submitted by some of our patients, and I would love to take a minute and ask you some of those, if that's okay.
Yeah.
All right. The first one is, I've been hearing this term specialty pharmacy. Can you tell us more about what it means? When I hear this term, I immediately think it means higher cost, but could I be wrong about that?
So, specialty pharmacy often does refer to medications that do have a higher cost. So, if we look at all of our biologic medications, these are medications that are pretty high cost, but they're also medications that oftentimes need a bit of extra help for the person. So, this is medications that are injectable, home injectables, medications that require a bit of counseling for somebody who's starting on a new medication. So while yes, oftentimes these medications happen to be more expensive, the specialty pharmacy does a lot more than just provide high cost medications. And now just because the medication is high cost for the insurance plan doesn't necessarily mean that it's going to be high cost for you. So for most people who have what we call commercial insurance, they're eligible for copay cards that will bring the cost of their medication down. And then for people on Medicare, oftentimes the costs we know with Medicare medications are Part D, they're quite high. And oftentimes people are eligible for patient assistance with those medications so that they can get the cost down. So while the initial cost is often quite high, the cost usually to the person who's taking the medication, we do our best to make sure that the cost is as low as possible.
And speaking of costs, I had another question, and it's really about Medicare Part D. I heard there's some changes coming to Medicare Part D. Is that something you can talk about? Or
Yeah,
they happened maybe?
So there are some changes that came for 2024, some changes to Medicare Part D, which are actually very positive changes. So the way that Medicare Part D is set up, usually there is what's called a deductible, where somebody is responsible for 100% of the cost. And this is, and I'm talking about the minimum. Every plan is different in Medicare Part D, which makes keeps us on our toes. But this is what the minimum is. So for Medicare Part D, and I have a little cheat sheet because I have trouble remembering the numbers. So there is a deductible where you would pay 100% of the cost. This year in 2024, $545 is the maximum deductible for 2024. And then after that, there's what they call the initial coverage phase. So the initial coverage phase currently either there's a copay or a co-insurance that the person would pay. So sometimes it's a percentage of the medication cost, sometimes it's a flat cost. And then that goes up to, and this is not what the person who has Medicare, this gets really confusing. This is not what the person who has Medicare Part D has to pay. This is the insurance plan plus the person paying has to go up to $5,030. So depending on the plan that you have, you're not going to pay up to $5,030. You will either pay a percentage or of the cost or a copay, and the maximum that you're supposed to pay is 25%, and then the plan pays the rest. And when that bundled together makes $5,030, then you go to what they call the donut hole. The donut hole is, again, up to 25% of the drug. And then the plan pays the rest up to a total of $8,000. So previously, that $8,000 cutoff was $12,000, so a bit higher. So that has gone down. What's really, really changed is when you get into what they call the catastrophic phase. Used to be 5% that the person was responsible for. It's now down to zero. So $0 for Medicare patients out of pocket once they hit the catastrophic phase. But what's really, really different about this is for most people, the maximum they should be paying out of pocket in total for Medicare Part D drugs is $3,300. And what I said, going into the initial coverage, the coverage gap, it's all very confusing, but what you have to look at is it's how much you pay plus how much the plan pays. And that ends up being for most people around $3,300 as a maximum for the year, which is a huge improvement over what we've seen in previous years. Previously people were spending upwards of $10,000, $12,000 for some of their specialty medications, which is really for anybody is kind of unreasonable. But now this maximum of $3,300 is a step in the right direction. And then for 2025, what we're looking at is a maximum of $2,000, which is really um, it's kind of music to my ears. It's still a lot of money, but it's music to my ears because we see it going down every single year, which means that medications are getting more accessible, and we like medications to be accessible, especially when we're talking about our vasculitis patients who oftentimes need therapies that are sometimes it can seem a little daunting with the cost of it. So, and even though we have patient assistance there and we do rely heavily on patient assistance, we see things starting to move in the right direction with the Medicare Part D plans, which is really exciting.
I appreciate you explaining that. I had recently just talked to somebody, a patient that that this actually, in fact, worked in their favor for the first time. Like she retired 2 years ago. She didn't realize that she would, after going from private insurance to Medicare, that she would pay more for her arthritis injectable medicine that she took monthly. Like I think she told me it was like $12,000 a year or something.
Mm-hmm.
And that this year, because of this change, she's now gone way, way, way down. And it's just hard for when people are go to retirement and some are living on a fixed income at that point. And so
Yep.
this is a great change to know about. We appreciate you breaking it down because it's so hard to understand, even when you get the publications and things in the mail.
Yeah,
So
it is. And honestly, for somebody who has experience with it, it's still, looking at it, I have to look at my cheat sheet to really kind of remember. They get so complex because they talk about, how much the person pays plus how much the plan pays, and then combine it all together and then what they call the true out-of-pocket cost. And it's just kind of mind-blowing. But that maximum, that kind of ceiling that you can hit with costs is really, really exciting to us.
also, the point you made about catastrophic, I don't know what that is, but when you get to catastrophic, to go from having to pay 5% of what happens at that point to zero, that's an amazing change.
It really is.
So again, thank you for explaining that to us. The next question is, someone wants to know if you can tell us more about biosimilars in rheumatology.
Yeah, so biosimilars in rheumatology. So this is, even though we've been using biosimilars in rheumatology for some time now, this has kind of come to a head last year and this year because one of the drugs in rheumatology that we use most, Humira or adalimumab, has come up to market with biosimilars. And there's actually 9 biosimilars on the market, if you can believe it, for Humira. Which is, it can get kind of confusing because every insurance company is kind of picking and choosing which they want to go with. I think the main points that we want to get across with the biosimilars, number one, they've been used in Europe for years. So even though this is new to us, the Humira biosimilars have been used in Europe for years. So they do have a track record of safety and efficacy that we can see from our colleagues in Europe. So, we're not particularly scared of the changes in biosimilars. They've been very well studied in, each individual company does their own studies that show that this medication is safe, it's effective for the conditions that it's supposed to treat, and also that it's not going to cause an immune reaction in people's bodies, because sometimes we worry about these really big molecules sometimes triggering an immune reaction. The companies have done these studies, and then we also have that data from our colleagues in Europe to lean on. So if you get a letter from your insurance company, which we're finding a lot of people right now for Humira getting these letters, it's okay. Just let your doctor's office know, and they'll be able to take care of whatever needs to be done. But I think, the biggest thing is don't be afraid of them, because they have been tried, they have been tested, and they've been used for multiple years.
Okay, and this maybe relates to that a little bit. Do insurance companies decide which biosimilars they will cover?
Oftentimes, yes. So we're seeing right now, so there's a big change coming in April of 2024. So Caremark is dropping Humira from their formulary, and they're going to be covering a brand called Hyrimoz. And then there's also an unbranded version of Hyrimoz that they will be covering. So a lot of people will be seeing this coming up. It's variable with the plan between each plan on what they're going to cover. It all has to do with who's given the best prices and what they can negotiate with between insurance company and drug manufacturer to choose the best cost for people. But I think, bottom line, we have to remember, cost aside, these medications are safe and effective.
Okay, I know some of these changes are difficult for people when they first hear about them. So it's good to have some of the thoughts and resources that you're giving us. One more question. I found, this is from a patient, I found the prior authorization process to be long and complicated and frustrating. Sometimes I've waited more than 3 weeks for authorization for a drug that I need. Any suggestion or ideas to get that answer sooner?
So sometimes we are at the whim of the insurance company. So regardless of how fast the doctor's office might work, it might respond to an inquiry from the insurance company. Sometimes they are not the fastest, unfortunately. And, even though we submit things and ask for them to be expedited, they're not always expedited. I think, my big tips, if you're on a medication and it requires prior authorization, those prior authorizations usually last a year. So set yourself a calendar reminder to let the doctor's office know, I need a new prior authorization when you know that it's coming, usually, within the month that it's coming, to prevent any delays, because like I said, the insurance companies sometimes take a little bit of time to either respond to the inquiry, or they have more questions and then take time to respond to that inquiry. If you know ahead of time, let the doctor's office know, because that way they can get started early and prevent any delays in getting medication moving forward.
Okay, thank you so much for all that help. And thank you so much for being our spokesperson on all of this information. And thank you so much, Rachael Parrott, for sharing all this information with us. And of course, to the Vasculitis Foundation for providing the educational webinar series, and Novartis and AstraZeneca, our sponsors this year. So thank you so much.
And thanks for having me.